So how has Levodopa evolved over the years from being an Ayurvedic remedy?
It's evolved in multiple ways, but the mainstay of therapy.
Why does Levodopa often produce the most consistent results?
We have, again, Levodopa in the form of Cinemet, which is an older version, and now we've gotten more. Sometimes the dopamine agonists cause a lot of sleepiness, a lot of fatigue.
So would you say one drug is better than the other, or it depends on the patient?
I would say that, again, as the disease progresses, we lean more on Levodopa. For some people, they may not tolerate it.
So how is it that you tailor Levodopa dosing based on the stage of the disease, the age, or patient response?
So we tailor it really about each person's quality of life. The way I look at Levodopa, we base it on, there's actually quite a few more medicines.
Are there practical tips you give patients to help optimize how and when they take Levodopa?
So again, it goes back to absorption. Early in the disease, as I commented, the neurons in the brain can store dopamine. So take it with... Welcome back to the Caring Neurologist, where science, stories, and breakthrough meet compassionate care. Today's episode is a fascinating deep dive into one of the most important discoveries in Parkinson's treatment history. It's Levodopa. It's a drug that has changed everything, yet even decades later, it's still evolving. I will take you through its legacy, the science behind how it works, and what the future may hold as the new formulations and delivery methods have emerged. So let's dive in.
So Dr. Thakkar, Levodopa has been around for decades, yet it's still the gold standard. Can you take us back to the early days? What's the history of this drug and how did it become such a turning point in Parkinson's care?
So this may be a long answer, but there's a lot about this medication, and it is the gold standard. The history of Levodopa starts with ancient roots. The use of L-Dopa dates back to centuries in ancient Indian Ayurvedic medicine, where powdered seeds, also known as Mucuna pruriens, also known as a velvet bean plant, which contains high levels of L-Dopa, were used to treat tremors back in the day. And when we look at more of the start of modern-day medicine in the 1930s, there was a Swiss biochemist, Marcus Guggenheim, that first isolated L-Dopa from broad beans. This is also known as Vicia faba. But when he himself experienced the medication, he got side effects of nausea, vomiting when he self-consumed it. And so it wasn't really recognized as an immediate therapeutic potential. By the 1950s, then a Swedish pharmacologist, Arvid Carlsson, conducted experiments. That was a crucial turning point. And he discovered that dopamine acts as a neurotransmitter in the brain. He showed that by giving another medicine called reserpin, which actually depleted dopamine, made someone look like they have Parkinson's. And when they gave reserpin to rabbits and they made an animal model of Parkinson's, it could be reversed by giving L-Dopa. And then the foundational work of Carlsson was awarded the Nobel Prize for Physiology and Medicine in the 2000 time period. But the clinical application and breakthrough came with an Austrian neuroscientist, Ole Hornigkix, who demonstrated marked deficiency in dopamine in the brains of Parkinson's patients in the 1960s. He and another physician, Dr. Walter Birkmeyer, conducted the first human trials, and they administered low-dose intravenous L-Dopa. They were able to observe, even though it was short-lived, improvements of these disabled patients, and ironically, they were able to help these patients, but it was met with a lot of skepticism in the scientific community. The major breakthrough came in 1967 when George Codius, an American physician, established effective tolerated regimens of high oral dose of L-Dopa that was slowly released, increased by dosage over many, many months, and patients then developed these revolutionary benefits that were, of course, causing them to be disabled, unable to walk and move, and all of a sudden they were able to walk. Now, one of the famous movies that have come out based on the breakthroughs of L-Dopa is The Awakenings, and this was basically on the work of George Codius. And then by 1969, Melvin Yarr published the first placebo-controlled study that confirmed that L-Dopa's superior in effectiveness for treating patients with Parkinson's.
So how has Levodopa evolved over the years from from being an Ayurvedic remedy per se to
Yeah,
what it is today?
It's evolved in multiple ways, but the mainstay of therapy that we've used since the 1960s, since Nixon was president, has been the immediate release carbidopa-levodopa. And carbidopa is actually a enzyme blocker to let levodopa not be metabolized in the blood and allows it to stay in as much of its form to get to the brain. So we really haven't had much evolution until the last 10, 15 years. And what we've seen is the evolution of levodopa is, yes, it was a tablet form, and we've got now capsule forms that allow for better absorption in the intestines. There's a branded version that now exists called Crexont, Crexont, and it's a better sustained absorption at the uptake in the small intestine, and it has a combination of immediate release and extended release so that the current uptake of levodopa is not only again absorbed better, but sustained better. The old immediate release that we've had for 50 plus years would really spike up and then just crash, and then patients would need the medication over and over again numerous times per day. We would start 3 times a day, and then after a few years, maybe 4 times a day, and then 5 times a day, and 6 times a day. And we have some patients, even 12 times a day, they have to take this medicine, almost every 2 hours. But with the extended release formulations, we've gotten these granules and pellets to allow for not only the absorption, but sustained longer and then less dependence of the medicine throughout the day. Now, we've also developed inhaled levodopa, which is a form called Inbrija, and that kind of helps with on-demand when patients' symptoms return quickly or abruptly, and there's absorption issues in the GI system, then you can inhale the levodopa and it kicks in a lot faster. The problem again, however, is the disease progresses, and then the oral tablets, they get metabolized very quickly. And as the disease progresses, there's absorption variability, and what we end up seeing is we need to get it more continuous. So in the last 10 years, we had a therapy called Duopa, or also known as Duodopa in Europe, and that was a GJ tubing system. It kind of looks like a feeding tube, but really effective, helps sustain and get plasma levels of dopamine much more continuous. Fortunately, in 2024, we had a new pump, but this was a subcutaneous, kind of like the insulin pumps we have nowadays, and it's called Vyalev, Vyalev. And this subcutaneous form of levodopa provides 24-hour continuous sustained absorption, and that's been revolutionary, especially in the last year when we've had this accessible for patients.
So does it mean that the more sustained the release is better for the body because you would have to take less of it, so there's less side effects?
Well, I can't say necessarily less side effects, but if it's continuous, then it's in the system, it's in the blood, it's already ready to be absorbed, and the brain has a healthy amount to use. What ends up happening is the dopamine levels, as a disease progresses, we lose its tonic stimulation. So in a healthy brain, dopamine already provides continuous tonic signaling, and that helps regulate movement. But when we give the oral medications, it provides a little bit of a boost. And when we get that boost, it's great, but it wears off. And then as the disease progresses, we start losing even that ability of the brain cells, the neurons, to store the dopamine. And that's why when you have it in a continuous fashion, it's kind of already there and ready to be released.
So what exactly is levodopa doing in the body? How does it affect dopamine levels and motor symptoms?
So I'm glad that you asked that. Levodopa is not dopamine, but it gets converted to dopamine. So levodopa is actually kind of very strong amino acids, and the body takes it up as if it's ingredients for a recipe. And then what we end up noticing is that the body will then self-create it into actual dopamine levels. So again, remember in Parkinson's, we're low on dopamine. L-dopa gets taken up and it gets metabolized. So one of the most important things is the way levodopa works in the body, it gets converted to dopamine in the brain. So when we are low on dopamine, we try to replace it, and we need to take levodopa. But the problem with dopamine itself, it doesn't cross the blood-brain barrier. Okay. And so we used levodopa as what's called a metabolic precursor, and it gets broken down by the body and then absorbed. So first you need to absorb the medication. It needs to be transported. And once it's transported and absorbed from the small intestine, travels through the bloodstream, then it goes through these special transporter proteins, L-type amino acids. And these are very specific barriers that the blood-brain barrier exists with, but it allows it to be converted to the brain. And then once it's converted in the brain to dopamine, and then there's other enzymes that we have that then help break it down and sustain the benefit. But it's, again, a difficult task because dopamine can't just be taken up by itself. We have to utilize L-Dopa to convert, and then we get symptom relief, because once dopamine's in the brain, then we can control symptoms, because the nerves that have lost the ability to produce dopamine is being replaced artificially.
So levodopa is naturally occurring in the body?
Unfortunately not. It's not naturally occurring. We have to take it in as a tablet or a strong supplement, and that way when we get it into the system, it gets broken down slowly.
Oh, that's fascinating. So some patients ask about dopamine agonist versus levodopa. Mechanistically, how do they differ? And why does levodopa often produce the most consistent results?
So we have, again, levodopa in the form of Cinemet, which is an older version, and now we've gotten more sustained, longer lasting capsules. But again, mechanistically, levodopa is converted to dopamine in the brain, and then it's kind of when it's taken up into dopamine, it's in the presynaptic, the early part of the brain, it's being taken up and then sends signals to other neurons and other pathways. Dopamine agonists, they directly bind to and activate dopamine receptors. So they act like dopamine, but they're not dopamine. So they mimic what a dopamine therapy would promote. Now, early in the disease, we have these pathways all intact, but they're still degenerating. Dopamine agonists bypass the degeneration and send signals postsynaptically. And they're maybe less potent, but the reason they're probably less potent than levodopa is it doesn't convert exactly to dopamine. It may mimic it. It gives symptomatic relief, but also they're dose limited. Sometimes the dopamine agonists cause a lot of sleepiness, a lot of fatigue. The other thing about dopamine agonists, they have longer half-life. They last a lot longer in the day, and they have extended release formulations, and they're pretty stable. They provide continuous stimulation to receptors, unlike levodopa that has a short half-life, about 90 minutes. It lasts maybe about 2 to 3 hours in the system, but levodopa fluctuates. Whereas, again, even though we have this variability of duration of effect, there's still limitations. For instance, levodopa stimulates dopamine receptors 1, 2, dopamine receptors 3 and 4 and 5. So there's 5 dopamine receptors in the brain. Whereas dopamine agonists, they only stimulate predominantly dopamine D2 and D3 receptors. So there are mechanistically different, not only how they bind, but where they bind. Now, there is some limitations of dopamine agonists. There's a difference in side effect profile. Like I said, sleepiness, fatigue. They can also create a little bit of impulsive behaviors. This can also happen with levodopa, but less so. And then as we need more and more levodopa, we develop dyskinesias. The medicine kicks in, it wears off, it kicks in, it wears off. And then the higher amount we give, we develop those involuntary movements. You don't really see that with dopamine agonists creating the dyskinesia. So those are the subtleties, those differences. With the dopamine agonist, we also have a patch form. Whereas with levodopa right now, we're still getting more continuous formulations, but not in a specific patch. It's more of a subcutaneous delivery system.
So would you say one drug is better than the other, or it depends on the patient, or how do
Yeah,
you?
I would say that, again, as the disease progresses, we lean more on levodopa. And again, that's why it's been always considered kind of the gold standard. And the particulars of levodopa, again, for some people, they may not tolerate it. Maybe they get nauseous. Maybe they get headaches. Maybe they have low blood pressure. And then we do depend on dopamine agonists if we need to. But I can't say that one is necessarily better. You end up seeing that we're more dependent on levodopa as the disease progresses. But I like to use them in combination. Sometimes early in the disease, we use a low-dose dopamine agonist and build up very slowly, but not get to a certain high level. And then we may incorporate levodopa as well. So again, they tag team the situation.
Okay, and there's a common myth that levodopa wears out. You already spoke a little bit about that, or that it stops working if taken early. Can you clarify what's really happening when patients feel its effects change over time?
Yeah, so this is actually one of the main reasons I'm doing this podcast is because of this myth that levodopa wears out or wears off and is not useful over time. All over the internet, there is websites and comments that, levodopa doesn't work. Well, it doesn't work well, and the oral tablet that they're talking about is the same one that we're talking about that was 50 years old. The immediate release carbidopa, levodopa that's existed for years, it kicks in quickly, it wears off quickly. And so there's always an absorption issue, and there's lack of the efficacy of that prescription medicine because it's short acting. So what we've really seen is levodopa remains the most effective type of medication for treating primary motor symptoms of Parkinson's. Delaying the use of levodopa does not slow down the disease progression. It doesn't prevent motor complications. Rather, it simply prolongs the period where a patient endures being untreated. We want to help their symptoms. We want to help the life-impacting aspects so that people can move more, exercise more. And the evidence suggests that when you give levodopa, it does not accelerate the disease, and people may feel that inherently it becomes less effective. It's really about the absorption. And that's why it's a myth, because you need to let it absorb better. And when we switch patients to Duopa or to Vyalev, you can start seeing it absorbs far better. And once it's absorbing again, because the pills don't necessarily get absorbed well for numerous reasons, then you start seeing that the response to levodopa in a gel form, in a subcutaneous form that gets into the blood, all of a sudden patients are responding again. So what ends up happening is the progression of disease itself is what is not letting the medicine work. It's not necessarily just a failure of the medication. And when we think about it, there's two main things. The loss of the storage capacity. In the brain, the neurons do not store the levodopa like they used to. So when we give levodopa, it doesn't let it absorb and sustain in the brain, and then it doesn't send the signals like it should. The other thing that affects that is the decreased buffering, which means as the disease progresses, there's fewer neurons available to store the dopamine. And so that's also another part of this, that dopamine levels become highly dependent on the timing of the pills. And then we have, again, the concentration wears off very quickly. But now that we have these longer formulations, the medicine does sustain better. It still may wear off because there's GI issues. Again, it's a short half-life. And another key point that I know the viewers are going to enjoy and try to take away is the medication needs to absorb, but can be blocked by other foods, especially protein.
So how is it that you tailor levodopa dosing based on the stage of the disease, the age, or patient response?
Yeah, so we tailor it really about each person's quality of life. The way I look at levodopa, we base it on how the symptoms are affecting quality of life. I have a examination that we always do. It's called a Unified Parkinson's Rating Scale, and that Unified Parkinson's Rating Scale is usually done by a lot of movement disorders, or should be done by all movement disorders. And we look at kind of the speed of movement, whether it's finger taps, fist opening, kind of how we are moving our arms, our facial expression, our voice, our muscle tone, our foot stomps, how we walk. So we use that motor score to see how someone's doing at that moment. And if they're having a tough time with writing, if they have a tough time with opening and closing their hand, if their facial expression's flat, if they're not speaking loud enough or don't have enunciation or inflection to their voice, then we start saying, okay, well, if it's affecting them at work or communicating, maybe we need to utilize levodopa. And we may use levodopa for really aggressive tremor or someone who's extremely rigid around the joints from the muscles. Then we may utilize levodopa. There's other medicines like the dopamine agonists we may use earlier, or even some of the non-dopamine therapies like rasagiline, which is an MAO-B inhibitor, or selegiline, or these are, again, other medicines that reduce the breakdown of dopamine in the system, but don't necessarily give you or mimic dopamine.
Thank you for clarifying that. I was going to ask if there were other treatments for earlier disease stages.
Yeah, there's actually quite a few more medicines. And again, in the last 10 years, we've had a robust amount of newer therapies. I think the future even looks brighter as we're doing more clinical trials, as there's new options.
And are there practical tips you give patients to help optimize how and when they take levodopa? You mentioned proteins interact. So how should they take it so that it acts better?
Yeah, so again, it goes back to absorption. Early in the disease, as I commented, the neurons in the brain can store dopamine. So when you take a pill, it absorbs, it's taken up, it's sustained, it can be stored, and then it can be delivered, right? But we don't necessarily need so much dopamine in the beginning. We try to build it up slowly. But again, as the disease progresses, we need to still make sure we're absorbing the therapy. But a lot of our patients get side effects in the beginning with levodopa, maybe upset stomach or nauseous, or they have reduced appetite when they take the prescription medicine. So they take it with food. Now, food may not necessarily block the medicine from working, but if it's a protein-rich meal, it will. And what I've seen in a lot of our patients, that if you took a protein-rich meal, more than like 10 grams of protein, whether it's like an avocado, an entire avocado, or one egg, or any bacon, chicken, fish, any of these protein-rich foods, it can block the area of the small intestine for up to 2 hours, and then the medicine won't work if you have it after such a protein-rich meal. So we try to tell patients, take the medicine at least an hour before a protein-rich meal, sometimes even 30 minutes, just because we want them to get the medicine in and then not have to wait too long for a meal. Some of our patients can take it with fruit or crackers, but again, it's protein that blocks the medication from being fully absorbed. And so we try to time levodopa evenly throughout the day. We don't like it 3 hours apart and then 5 hours apart and then 6 hours apart. We like to keep it nice and even. If it's every 5 hours, that'd be great, or every 4 hours, but we don't want there to be so much variability in the day. So I always recommend start early in the morning when you wake up. I think of levodopa as a fuel. Just like you would be driving a car, you need to fill up the gasoline. You don't wait until you're at the designated spot where you're driving to then fill up gasoline. You need it ahead of time. So start early, get the medicine in your system, let it build up. And then that also, again, as we know, levodopa doesn't help only motor symptoms. It can help the non-motor symptoms. It helps the mood, the thinking, the processing, and concentration too.
So would Parkinson's patients benefit from a plant-based diet, or does plant-based protein also affect the absorption, or would you say only animal protein?
No, I think any form of protein can block it. So even if it's animal-based and there's a lot of beans, a lot of legumes, again, like as I commented with like avocados, it can have a high amount of protein. It could even still block the medication from working effectively. Now, early in the disease, a lot of people may not notice that variability of certain foods blocking levodopa. But as time goes on, you start seeing that there is some limitations in how it can be absorbed.
And on another note, you've mentioned the inhalable levodopa, long-acting delivery systems, and even intestinal gel infusions. What future advancements in delivery are you most optimistic about?
Getting a sustained long-acting form of levodopa. If we can just get like a once-a-day form, an oral tablet or a capsule of levodopa that can, slowly deliver levodopa so it's just where it needs to absorb and not have patients need to keep taking the medicine numerous times per day, that'd be great. I've seen a great amount of positive response with the Crexont extended release levodopa. But again, we're also seeing the subcutaneous form that I commented earlier called Vyalev. That has really been useful, and that's been a great advancement. As far as future advancement, can those pumps be smaller? Can it get to the level where it's just like a tiny little patch like we have right now with the insulin pumps? That would be amazing. And, again, not only just can levodopa be, less frequent or just in a smaller pump, like can it be even more effective? Can we be more specific in dopamine pathways in the system?
So levodopa, it's a great drug, is an effective drug. It would be a huge advancement if it was only a time release. Is that?
Yeah, I mean, if it could be just once daily, that would be amazing. And the problem is, even with our extended release forms, we still have to give it numerous times per day.
Are researchers exploring new ways to combine levodopa with other therapies to enhance its effect or duration?
Yeah, they are. Researchers are actively exploring new ways to combine levodopa with other therapies, focusing on new novel administration methods, new adjunct medications, how we integrate even non-dopamine agents, and even such as gene therapy to enhance the effects and duration of levodopa to reduce those motor fluctuations. So we are seeing that there is a significant amount of studies with that gene therapy to let levodopa absorb and dopamine stores to sustain. There's also newer drugs that are available, tavapadon, which is a selective dopamine agonist. That's in clinical trials, and that's mimicking more like our typical levodopa therapies, and that's showing promise of improving motor control as it's focusing on more D1 and D5 receptors as opposed to the old dopamine agonists that are D2, D3 receptors that have a lot of side effects. This newer version looks like it's going to be very good to combine with levodopa or even reduce the amount of levodopa so that symptoms have better control. So as I commented, gene therapy is one of the more promising avenues to enhance the brain's availability of levodopa or other dopamine. And then we're hoping that maybe even stem cells could help other pathways to allow levodopa to work better.
Are there any non-medication treatments that help with the functioning of levodopa? Something that's lifestyle related?
Yeah, so as we've commented on previous episodes, it's all about the exercise. The more you exercise, the more you keep those connections going. I think those are extremely important aspects. It's not just about dopamine. If we could just replace dopamine, that'd be great, but other dopamine pathways that are associated pathways, norepinephrine, serotonergic pathways, acetylcholine pathways, memory testing and processing and learning new techniques is going to be key. kind of training your brain like you were in college or in high school, and testing your brain and pushing it to the limits with math and science. And I think that's extremely important. But exercise is going to be the key for that motor control, helps you sleep better. And one of the other aspects about non-medication to enhance, meaning there's some data that says vitamin C at the time of levodopa may help with the absorption. Those are unique things that we still need to explore.
So I'm guessing even learning a new instrument or learning an instrument at all to play an instrument could be helpful then for someone with Parkinson's.
Sure. I think, again, when you're younger, in your 20s, in your 30s, in your 40s, it is important to keep learning, keep those pathways going. I think that's actually when we start seeing the onset actually of Parkinson's in our 40s and 50s. By the time we're in our 60s is when the disease has already become a disease and has reduced 80% of our storage capacity of dopamine pathways. So it's what you're learning in your and you're coordinating in your 30s and 40s. I think that's the key. And so if you can learn to and do a new, like use a new instrument or develop the skills for the piano or the guitar or even dancing, I mean, there's so much that can be done, and the brain needs to continuously learn and evolve, but at the same time, it needs to be trained, and you need to work on different pathways. Even linguistically, if you learn a new language, maybe that could help the dementia components, the processing components, so maybe we don't develop, Alzheimer's.
And for someone newly prescribed levodopa and feeling nervous or overwhelmed, what's one message you'd want to leave them with?
Yeah, I think there's a lot of myths out there. And one of the big myths is that when you start it at a certain point, you think it's not going to be effective. That's not true. I think, it's important to start a medicine to help sustain quality of life. There's just a recent data that shows that starting it earlier is better, and not instead of waiting. When you start the medication early, you're allowing your body to coordinate better. And that's what's going to help you actually fight this disease so that you can exercise, so you can focus on your work better, so you can have better communication with family. Because dopamine from levodopa isn't just about a tremor control or stiffness control or walking. It's really about how you feel. Does it make you feel more motivated? Is it helping you think? Because other pathways of the brain still need dopamine. And again, a lot of our patients also feel very depressed and lack of motivation, whether it's to eat certain foods or to exercise. You end up seeing that levodopa, again, is pretty darn miraculous. It helps with giving function. And that's one of the reasons why I was thinking I was going to be an epileptologist. And when I saw someone with Parkinson's and I started to give them levodopa, when they came into my clinic 3 weeks later, all of a sudden they're walking to my clinic. They weren't in a wheelchair. I mean, it really felt like I gave them life back. So, if you are a movie buff and you wanted to watch The Awakenings, you'll get that understanding, that feeling that I experienced, that you brought someone back to life.
Well, I'm definitely going to watch The Awakenings as we finish this episode. And we have reached the end of the episode. Dr. Thakkar, is there anything you want to leave the audience with? One last message?
Yeah, I think one of the things is this episode is one of the key integral parts of Parkinson's management. Levodopa, it's the integral part. It's something I talk about every single day with patients. And it is something that has not only the benefits of therapy, but also has created a lot of fears for patients. It is the appropriate therapy, and if it's given correctly, just like anything. So we don't want to over-medicate, and I really believe that if we can keep the levels low and sustain it, we can get more patients on more subcutaneous formulations. I think that's the best, so we don't feel like we depend on more and more pills to reach a certain on time. And then again, sometimes we're chasing this off period of when symptoms come back that we just take more and more pills. Try to start at low levels and keep it at low levels indefinitely.
Levodopa has stood the test of time, not because it's old, but because it works. Dr. Thakkar, thank you for guiding us through its remarkable story and reminding us that progress in medicine often starts with curiosity, persistence, and care. If today's episode helped you better understand your treatment or sparked new questions, be sure to subscribe and share the Caring Neurologist with someone who could benefit. Join us next time as we continue exploring the breakthroughs shaping the future of Parkinson's care.
Thank you.